is this is the ulnar, okay? That's the ulnar test. I showed you yesterday. This is the radial test, okay? And you can already see what's happening here when you engage the wrist in the extension. You're already starting to stretch the radial head capsule and tendon, okay? So there's your radial head test. And then if it's a positive radial head, the majority of them do go laterally, but there are a small percentage of them that go to the other side. And how does that testing look? For that is basically you make a fist right here now, make a fist, turn that over, and then you're going to ask the patient to pull towards you, and does that create any elbow pain? No. Okay. If it does, now the radial head is subluxed laterally. Okay. And if it's not, and if you do this test now, you can confirm that it has gone medial and superior. Okay. So pull, and it's not painful, but he's failing the test here. Okay. So now we've got tenderness. There's three things right there. That's three positives right there for a lateral head displacement of the radial head. Okay. It usually goes this way and superior. So basically, you're just taking the wrist. Now you're going to make you get a little contact here, and you're going to torque the wrist over and down, and that's about right there, and you make your little snap. Okay, a nice little crisp snap, not a recoil, ever a recoil, never recoil this one. It's always take all the tension out and snap. Okay, just do it fast. You know, if you sit around with a lot of these adjustments and you play around with them forever and you're scaring the heck out of the patient, okay, you could be causing apprehension. So a lot of these adjustments need to be done quick and fast so that they don't have time to really to get into any thought process about what you're doing. If you can hurry up and catch the patient, and I don't mean scare them or anything but just be kind of quick and brisk with a lot of them. So, and then our lateral, now we've got our all in the test positive. Okay, it's going down, it's mushy. So you're going to take the wrist now and you're going to torque it the other way. hit the median ulnar area and through the elbow right in here, giving it you can always see that there's always a nice big knot that goes with this problem here, this median elbow, because what's happening when this thing is contracting is it's yanking the elbow out and deviating towards the midline. Okay, if this starts yanking, it's going to start causing and this is a big problem in pitchers this patient usually shows up every year about my office at about springtime, and you'll get at least 5 or 6 of them if you're in any kind of baseball program. Median ulnar deviation, and they said, well, after you're doing your history, one thing that really starts to bring this problem out is curveballs, sliders. Anytime the elbow is coming through a full range of over the top, there's not very much problem to go wrong with the elbow. But when they start trying to put some funk on the ball, okay, the first thing they start to do is drag the elbow down and out so the ball torques and twists and moves. Okay, you can't really put any mojo on the ball unless you have a leading elbow first and then a funky flip on the end. Okay, so and if they bring that pitch up, all of a sudden we're going to start learning today. Hey, guess what, Joey? We're going to teach you how to throw a slider. We're going to throw like 30 of them today. And then his kid comes after it. Next day he wakes up. Oh, wow. Oh, that's your guy, that's your boy. And you just always pin it back to, in your history, he's adding a new pitch to his problems now, or his repertoire. His problems. Yeah, his problems, because baseball, it is what it is. You have to do what you need to do with the elbow to drop the ball, and you may even come over in all kinds of crazy ways. So that in your history, then you can say, well, listen, guy, I'm going to fix your elbow. But if you go back and you throw more than 5 or 6 of these at any outing, you're going to start running into problems. You're going to start earlier with these crazy pitches, okay? Because the elbow will adjust to this pitch. It's just that it can't do too much too soon. And that's the problem with these athletes. They're doing way too many of them, way too fast. Okay, it's not so bad that they throw them. It's the problem is too much, too soon. And then they strain the medial ulna, Then they add another throwing session 2 days later, and then the whole problem starts compounding. Yeah, so then we're going to come back in here. Now we have a lot of work to do on this athlete, and then we're always assume that there's going to be some posterior scapular problems to begin with in a pitcher. You just assume automatically, pitcher, you need scapular work like crazy, okay? Okay, so we're going to make our ulnar correction in here by simply having the patient lying on his back, getting a web contact with your hand right in here and snap, okay? And I showed you how to do that yesterday. So we have the testing for the ulna, we have the radial head test, and then we have to differentiate, has it gone medial or has it gone towards the midline? I mean, lateral or medial. So and then that is the test. Make a fist, and then pull away. Okay, no, yes, okay, so we're going to, now we have, he's painful for a midline deviation. So now we're going to come back into the radial head, and you can feel the radial head on this side of a bone, and then find that head, and then you're going to slowly keep turning it till you find that the radial head. Ah, there it is, right there. Okay, so now you can either make 1 or 2 corrections here. You can turn the wrist and thrust out, and then turn the wrist one more time, bend it, and thrust one more time again. So kind of play with that adjustment, see what you like. I'll bring the radial head into my finger and hit it one more time. Okay, then I might take it over to the outside again, and then slightly flex the arm, and then one more time back out on the radial head, going that way. Okay. Okay. So now we're going to move into some of the shoulder adjustments again, and let's go back over here to the table.